I am the Executive Director, Home Infusion, as I refer to, down the hill. We used to actually be here. Now, how many folks have been here at least 15 years? All right? I don't know if you recall, our pharmacy originally, when I arrived, was actually at the end of the hall. It was literally not much bigger than this area right here. And when it came time for us to relocate, in order to get our hoods out of that area, they literally had to bring a crane with a flatbed and bring it up to the third floor window, take the glass out of the window and actually roll the hoods out on this crane lift and slide it over and put it on a flatbed truck and drive it over to 1601 Abbey Place. So we have been blessed to have grown quite a bit. For those of you who have been around for a while, we have grown quite a bit. I teach pharmacy students. I love to draw. I am no artist, but I do love to draw. My official title is Executive Director, but as I tell most folks, I'm more like the janitor. I'm the guy cleaning up messes that get made. Some days like a firefighter, stomping out fires that get started from different places. Does anyone really have a clue why I'm here today? Has Marie shared that with you? Can you give us insight? No?
Yeah, it's mandatory.
Yeah, it's mandatory. Yeah. Just show up, right? I don't know if she said free beer afterward or not, but that's one way to get an audience. That's for darn sure. I'm here to actually support all of you. Now, I am curious, how many nurses, RNs, do we have in the group? Show of hands. Great. Any LPNs? Therapists then? All right, great. About half and half. Excellent. I am actually here to be a support to you, to help maybe provide you with some information to keep you out of trouble when it comes to the medical legal world. I sit on our Sentinel Event Task Force. Everybody knows what a Sentinel event is. That is a unfortunate event that happens, death, injury to a patient while they're under our care. And folks, I'll tell you right now, it is a heinous thing to go through. Being in this business a long time, being in charge I have for a long time, when you are involved with an event and you're being deposed by an attorney, let me make this abundantly clear. In their eyes, you're guilty, we're going to prove it, and we're just going to reach in your pocket and take your life away and your money. That's the attitude you will find when you are in a malpractice type event. So when I'm sitting on the Sentinel Event Task Force, we unfortunately have things happen, and we have to review all of these cases to make sure that, did we do everything we should do? Did we do something we should not have done or not do something? So we can minimize the risk to the department and to you. Over the last, 10 months, 12 months, I suppose, we've begun to see somewhat of a theme or some consistency as we've had these Sentinel event conversations, and it seems to include drug interactions and mainly anticoagulation. So as we have kind of talked through these things, I began to realize perhaps there is kind of a disconnect or maybe some more information that needs to go out. What we identified, again, this is probably 6 months or so ago, was that there are drug interactions that you see out of home care, home base, and they're not always being reported directly to the physician. So when you have that type of Sentinel event conversation and you find there's a weakness, then we as leaders do what we as leaders do. We make a decree, right? Thou shalt from now on always call the physician when you have a level 1 interaction. Sounds good. It's easy to sit in the throne and say, thou shalt, right? But it's not always practical for the boots on the ground. So our quality team, after the decree was sent, our quality team did what they normally do. They do an audit. And that audit came back with some disappointing numbers. So if you look at your front page on your handout, you'll see that in totality, we as Healthy at Home, this is all the branches, scored a whopping 16% in terms of notifying the physician when a level 1 interaction was identified. If you look on the back side, or the second page, you'll see where you, as your branch here, scored on this particular audit. And we scored anywhere from 0 to a high of 50% throughout the sum of the branches. So there again, when we see these type of numbers, it's concerning because when you're in a sentinel event situation, when you're talking about medical legal issues, oh my, are we at risk? And if so, how can we help provide support to the staff to mitigate that risk? So I talked to Robin and asked her to share with me what are these drug interactions that are occurring. So this is the official list, as you see here. This is the list Robin gave me. This is the most common level 1 drug interactions that are reported to you out of home care home base. Now everything I'm going to talk about is simply home care home base because that's the world you live in. And quite frankly, folks, when I saw this list, and Robin, to tell you, I kind of chuckled because some of the things on this list, in my mind, don't really necessitate an urgent phone call to the physician. There are times that we need to do that, and there's times it's not that critical. Faxing information is fine. So we're going to kind of talk about when you need to set your hair on fire and make sure the doctor gets this information, and when it's probably okay just to fax the information as well. Now, being a pharmacist, I took the next step, took this list, and simply put it into buckets. So if you look on the other side, I simply arranged these drug interactions kind of by the class of drugs that they are. And guess what? Holy moly, you see there's a theme here. The majority of them are all wrapped around what? The statin drugs. Now, why do you think the statin drugs are the most commonly reported level 1 interactions coming out of home care home base? Because everybody's on it, right? Why is everybody on it? Because they're sick, and that's the reason they need home care. It goes hand in hand. The reason you're involved is because they are at that stage. So it is a very common drug that you're going to see. You'll also note metoclopramide, Reglan is also on this list. And there's a lot of interactions there. So we're just going to kind of talk about some of these. And of course, my favorite is on this list. Now, this is actually a level 1 drug interaction from home care home base. And it's Flagyl and alcohol. Now, does anybody have any idea what could possibly happen as a reaction with Flagyl and alcohol? It has the potential to induce what we call a disulfiram-like reaction. Disulfiram is actually a medication we give to alcoholics as a deterrent to drink. They take their disulfiram in the morning. If they drink later in the day, they could vomit, have nausea, and it discourages them from doing it twice. So what happens when you are talking to a patient and they're on Flagyl and they are talking about having a glass of wine tonight? Guess what? Who cares? What happens if they get sick and vomit? They ain't doing it twice, right? You're not going to call a doctor and say, doctor, you know, my patient here is wanting to drink a glass of wine, and there's a level 1 interaction at home base. So they might vomit. What do I do? Let them vomit, right? My point is there are some things that are harmful and dangerous. Some things are irritating. This is not one of those dangerous type events that necessitates getting the doctor on the phone to make them aware of this. They already know it. So that's kind of what we're going to walk through a little bit. How do we understand this, right? When you get a level 1 interaction, anybody, when you get a level 1 interaction, reported to you. What do? What's the first thing you should check when you get this information out of home care home base? What's the first thing you should look for? Excellent, right? Are they symptomatic? Symptomatic to what? What are the possible symptoms? That's another good question. But the first thing you should check is how long have they actually been on this combination of drugs? Because a lot of these interactions are referred to as contraindications. Now, again, when I was in pharmacy school, when we heard contraindications, it's like warning, danger, Will Robinson, can't do that, something's going to happen, right? But that's not necessarily the case. It does mean pay attention. It does mean watch a little closer, but it doesn't mean imminent danger or harm to the patient. It just increased the possibility. What is a contraindication? Well, I kind of shared with you in here the official definition. It is simply something that may influence, render this therapy inadvisable. Okay, so let's take a look at the statin drugs since that's our most common. What is the something related to this list of statin drugs that you see? Well, in this particular case, it is a reaction called myopathy, which is muscle weakness. Now, it could progress to something a little more serious called rhabdomyolysis. And you hear that and it's like, oh my gosh, that sounds horrible. I don't want that to happen to anybody. Of course not. But if you were to study this particular interaction, it's actually listed as a minor drug interaction. Why? But it's a level 1, it's a contraindication. But why is it now considered also minor? Why? Anybody? Because it doesn't happen that often, and it's easily remedied by simply reducing the dose. So imagine you get this level 1 interaction report, and you got a statin drug on it, and let's pick one, amlodipine, right? A calcium channel blocker or a medication used for cardiovascular service. I mean, you're going to see these combinations, right? And you get on the phone and you call the doctor. I just got to let you know, doc, there's a level 1 interaction. But yet, 6 months ago, he's already reduced that dose of medication. He's already addressed it. What happens is we, the clinicians in the field, and I'm a clinical pharmacist, I've made these errors because I didn't give the physician enough quality information for him to listen to a real concern. So what I want you to be mindful of is before you make that call, you need to do a little assessment. Okay, there's a possibility there's a concern here. Let's take a closer look. How long have they been on this combination? Say 6 months or longer, right? Because this is what happens in our world. This patient has been in the hospital, they've been seen by the doctor here, they go back to the hospital, seen by the doctor, right? And they get older, and all of a sudden, we in home care get involved in one point in time, right? And then we pull out, and they go back to seeing their doctor. So we just show up at some point in time, and then all of a sudden, we're running around saying, warning, danger, warning, danger. But are we giving that physician quality information so that when we call back the next time, they're going to actually listen? I'm just curious. How many of you folks actually get the physician on the phone when you have one of these events, right? It doesn't happen. And what we don't want to occur is that we cry wolf so much that when the wolf finally shows up, no one's listening. So one of the things I want you to just be mindful of, if we go through this and we're looking at it, we're assessing, we know what's going on, there are times we do need to set our hair on fire and warn the physician that something's going on. So what's the difference, right? Somebody said it earlier. Are they symptomatic? So let's think about this. All right, they've been on a statin drug. You get this list that's a level 1 interaction, and they start, again, amlodipine, any of them that's on this list. And it's a new medication. All right, you need to be mindful. You need to be aware that there could be something going on. So you have to assess and you have to ask the patient. Mr. Miss Patient, be mindful. There is a possibility that you could have a reaction here, and it could look like this. Are you experiencing anything like flu-like symptoms, unusual malaise, just weakness, dizziness, tiredness? And if they start saying, yes, as a matter of fact, over the last number of days, I have felt unusually tired. Folks, that's a different conversation. That's when you need to, when you call the physician's office, you need to make sure they understand this is a new drug combination the patient's on, and it appears they are symptomatic, actually demonstrating the side effects that we're warned against. That's a different conversation. Metoclopramide. Again, I talk about it because it's on your list, and there's a lot of interactions. We see this drug frequently. Why? Well, duh, because our patients need it because it's GI related, right? Just so happens the mechanism of action of Reglan interacts with dopamine type receptors. Now, if you remember way back in your days of schooling, what other class of drugs deals with dopamine type receptors? All your antipsychotics, right? They all interact with dopamine, norepi, serotonin. So when you give a drug that has a potential to interact with that, guess what? Every single side effect you see on that list, they're related to an antipsychotic drug. So if you are out in the field and again you get a patient that is new to this combination, what will you be looking for? What do you think would be a common concern you have? What's our number one concern here in home care with our patients, right? Falls. So when you see this combination, you're dealing with antipsychotic drugs, what are you going to zero in on? Say it again?
Falls training.
Right? Why? Because they could be at higher risk of dizziness, right? If you were to look at, this is interesting, if you were to look at, now, Facts and Comparison is the reference book I love so much. If you were to look at that number of adverse drug reactions associated with antipsychotic drugs, guess what? There are 6 freaking pages. Everything interacts with antipsychotic drugs. So when you see that in your patients, again, be mindful. Risk of falls is significant. And if you have a drug interaction, just, again, make sure the patient's aware. Be mindful of dizziness. Be mindful of things. But again, if you must assess how long have they been on it. Have they been on it for a while? Are they symptomatic? If not, that's a different conversation. So what is this drug interaction thing all about anyway? Because we're going to shift gears here in a minute. We're going to talk about drug interactions in general, and then we're going to talk more specifically about anticoagulation. What's going on with this whole drug interaction thing? We're going to take you back. I know I'm going to hear the moans and groans. I'm going to take you back in time to anatomy and physiology. Because I want you to really understand this. Because it really puts things in perspective in terms of what is this drug interaction thing all about? What's driving it? And why do we care and why do we not care sometimes? Now, I've already warned you, I am no artist, and I'm going to prove it. This is your body. This is the human body. My students flip out when I introduce this concept to them. I actually have a few pharmacists, I don't think really believe me yet either, but this is very important to understand from an anatomic point of view. The inside of your intestines, the inside of your stomach is the outside of your body. Does everyone understand that? This is your mouth, this is your stomach, this is your rectum. It's nothing but a straight garden hose. That's all it is. And if I open my mouth, open the rectum, then air can simply come through like this. Inside of my body, it's actually the outside of my body. Anatomically, it's all it is, just one straight garden hose. So what, right? This is your intestines. How many of you make coffee? Anybody ever in here make coffee? Show of hands, all right, you know what I'm talking about. How many of you use coffee filters, right? Your intestine is literally like the coffee filter. When you're making coffee, You take a filter and you put the grounds in the filter. Then you pour the water in. Same thing here. You don't drink the grounds, you drink the remnant. You drink the brew that comes through the grounds, right? That goes through the intestines into the cup. The exact same thing happens here. You don't consume, the grounds don't go into your intestines. No, only the brew does. The rest of it is simply expelled into the toilet. Okay, so what? Inside your intestinal system is a very, very elaborate vascular system we call the mesentery. This is where it gets interesting, because every single thing you swallow, medications, poisons, food, it doesn't matter what, all of it comes across that coffee filter into the mesentery, and guess what? All of these vessels come into one vessel that we call the hepatic portal vein. And it feeds directly into the liver. Everything. Nothing goes to your big toe, nothing goes to your brain until it goes through the liver. Everything here goes directly to the liver. Then it gets expelled. Okay. So what? Well, this is where the so what hits the road, because I love the liver. It is a magnificent organ. It does so many metabolic functions. So when you are consuming anything, it's got to go through the liver. Same thing with these medications. Drug A, drug B is going into the liver. Now, it just so happens there are some very elaborate metabolic enzyme systems in the liver, and there's several of them. But the one that is most predominant, the one that you'll see is most common with these adverse drug reactions and these drug interactions, is what we call the cytochrome P450 system. And again, there's several of them, but this is kind of the most commonly used. Cyto, it's just a fancy name. Cyto simply means cell. P is just got a heme factor P in it, pigment. And 450 is simply the light absorption that when you're doing spectroscopy and you're trying to identify which enzyme system it is, that's all it is. So it's just a naming nomenclature. But this is where it resides. This is where it works. So what happens with a drug interaction? Well, most commonly, if you've got two drugs that use this same system, guess what? There's going to be a little competition going on, right? You know, when I was in elementary school, the lunch bell rang, we all charged to the cafeteria. And guess what? You're trying to get through that one door, and everybody's trying to fit in at the same time, and you can't. So you had to kind of wait your turn, but eventually you got through. Well, folks, that's exactly what's happening here. These drugs come into the liver, and they're fighting, jockeying for a position going through this enzyme system. So there can be a difference in how they're handled. Drug A, drug B in the blood. So when these drugs are going through it, here's another caveat. Drug A might have the ability to speed this up or slow it down. And guess what's going to happen? If that's happening, drug B could be reduced in terms of the amount that's in the blood. It could be eliminated from in the urine faster, right? Or vice versa. It could be slowed down, you know, kind of like we feel in the morning when we're trying to get up, right? It could be slowed down and last longer because guess what? Dang, that drug A is constantly in my way and I just can't get metabolized. So what do we do about this? Anybody. We recognize it, and what do? We simply adjust the dose. Perfect example. I'm sure a lot of you see a lot of our solid organ transplant patients. They're all on immunosuppressive called Prograf, tacrolimus. Well, one of the drug interactions with tacrolimus is grapefruit juice. Because guess what? Grapefruit juice actually interacts this enzyme system. So what do you tell a patient? Or that is an option. Or what else do you tell your patient? How about, Mr. Miss Patient, we're going to monitor your drug level. You drink that grapefruit juice like you've been drinking it. Don't change, just drink it like you've been drinking it. And you know what? We're going to either increase or decrease your dose so that you can enjoy your grapefruit juice, because they read on the internet drinking grapefruit juice was healthy, so they're going to do it, right? Because everything on the internet is true. So all we do is say, keep doing what you're doing. We will monitor and adjust the dose accordingly. Make sure it's therapeutic and make sure you're not having side effects. But again, this is where it comes into play. When this event is occurring, and guess what? A drug level is going up unexpectedly, and the patient is starting to have, some type of reaction, and you're not sure what's causing it. It could very easily be driven right here. That's the reason when you get these drug interaction reports, we have to back up and we have to say, this could be a concern. Let's take a closer look. The term I always use for my students is be a better detective. Look at the information, make a good decision. So we have to back up and examine how long have they been on it, are they symptomatic, and do their symptoms match up with what is being reported as a possible drug interaction. Any questions about this? Yes, ma'am. Wow, what an excellent observation and what an excellent comment. Absolutely. This is what I teach all my pharmacy students. Any drug can cause any problem in any patient anytime. And you're different than I am. And absolutely, positively correct. Factor in this liver is a precious organ, but I like to drink a lot. Factor in this is a precious organ, but I get chemotherapy. So guess what can happen? The hepatocytes that actually operate this thing can be damaged. But yes, your makeup is different from my makeup. My wife, back in the day, she could literally take 2 Tylenol and it would put her to sleep. She could drink a cup of coffee at 2 o'clock in the afternoon and keep her awake. Hell, I can drink a cup of coffee at 9:30 and be asleep at 9:31. It's just a different metabolic process. Absolutely. That's the reason some people can drink 1 glass of wine and be out of their mind, and some of us, it takes about 3 bottles before we get there. But we keep trying, right? But yes, excellent observation. Did everyone hear that question? All right, the question was, with some of the patients, they experience multiple drug interactions or multiple reactions to medications they're taking. Is that due to how they are processed here? Yes, because everyone is different. And that's the reason we have to be mindful, and that's the reason we have to back up and try to mate up the symptoms to the patient to the possibility. Yes, ma'am.
A lot of drugs, though, have the same side effects. So, like, when they're on all this polypharmacy stuff, how do you discern what goes with what drug?
Well, the truth to that, or the answer that we literally have to go through, is you got to take them one at a time. You literally have to examine them one at a time. One of the things we're taught as clinical pharmacists is when you're making a drug change, for example, hypertension, you don't say, you know what, I'm just going to start you off on 5 medications. Because you don't know, and guess what? They normalize with their blood pressure. And you say, congratulations, I fixed you. But you don't know if it took all 5 or number 3 worked and the others didn't. You don't know. So you have to do it one at a time. And that's what we have to do many times here, is remove them one at a time and see how we can address it. Excellent question. Yes, ma'am.
With an aging liver, does that enzyme production get decreased over time and end up impacting what gets stored in the liver?
2 parts to that question. As we age, I think that's what she said anyway. I'm getting there. As we age, does that affect the processing? Yes. Storage is not an aspect here, only metabolic function. There is something called fatty liver, which I'll bore you with later, but that's not related to drugs and that's not related to storage. That's actually overconsumption of dextrose, interestingly enough. But an excellent question. And that is one of the things we have to be very mindful of, because that is a risk factor that gets pulled into this. And we're going to talk about risk factors a little more as we talk about anticoagulation. Excellent question. Anybody else? All right, yes, ma'am.
What kind of, do you, like, we'll see it, it'll come up like as a, do we have any resources that tell us, it'll say severe interaction, you know, moderate interaction or whatever, but I don't know what to tell the patient, you know, this consumption of grapefruit juice, what is causing this interaction? Or is, and also, is there a way, like, that you pharmacists may know which medication would dominate over another medication with the same enzyme?
All right, excellent question. And I'm going to ask you to hold that till the end, because we're going to loop back to that. And it was about resources. How can I get some more specific guidance as to what the interaction may be, and how can I clarify what it may be and warn the patient, make the patient aware of what's going on. Hold that to the end, because Robin's going to probably have some additional information to answer that. All right, so we're going to shift gears here, folks, and we're going to start talking about some anticoagulation. Now, first and foremost, I have to make this abundantly clear. Of all the sentinel event conversations I've been involved with for years, I have never, right? I've never had a conversation about, gee whiz, you know, we had a statin drug event and the patient had a problem. We've never had that conversation. All right, so go back to this particular list. This doesn't scare me in the sentinel event world, quite frankly. However, this does. This is our number one drug when we are having conversations about sentinel events. Here we go. So this is where the rubber hits the road. And that's the reason I want to put a little extra emphasis on this. I wanted to kind of explain kind of what's driving some of this stuff first, so hopefully it'll make this stand out a little bit more. I purposely did not give you all the tree as far as the cascading effect. If you want it, I'll be happy to bore you with it. But I wanted to emphasize some key aspects here. Now, at the very bottom, this is your clot. The insoluble fibrin, that's the clot. That's what we're trying to prevent. And you notice we have the intrinsic and we have the extrinsic kind of, you know, cascading event. Intrinsic is inside the blood. And we'll talk about this a little bit more. These little balls that float around, we call them platelets, right? So we've got the intrinsic, which is inside the blood, and we have the extrinsic. Now, extrinsic is when you're chopping onions, you know, making dinner and so forth, and you cut your finger with the knife, and it starts to bleed, okay? Then you got this cascade system that steps in and begins to recognize, holy cow, we got a leak, we got to plug it, let's go to work. And it does. And you'll see there's different places that has to be activated for this to work. It's a very sophisticated, very complex system, and very effective, obviously. So you'll see we've got different types of anticoagulation agents. The low molecular weight heparins, enoxaparin, you know, one of the first to come out. It works specifically, as you see, on 10A, so one place it works. And then we've got good old heparin. You know, heparin can prevent clots. Heparin can obviously lyse clots. That's the reason when you get DVTs in your calves, this is what we put you in the hospital, give you a continuous heparin infusion to help lyse those clots. But again, you see where it works is rather specific. Prothrombin, thrombin, okay? These things have to be activated. Then you've got the new class of medications, Pradaxa. And you see this interacts more specifically with the fibrin down here interaction. And then, of course, Xarelto, rivaroxaban, that's blocking 10 to 10A. Again, very much like, it's like the oral version of enoxaparin. We use Lovenox, when we want to start quick, finish quick, and then this agent is what you can take continuously. Now, if you watch the commercials as I do, and I'm always intrigued to watch these medical commercials, right? There's always a common theme. Well, I wasn't feeling good. My doctor wanted to put me on warfarin, but I didn't think that was going to be a very good thing. So my doctor says Xarelto, and I feel great. Xarelto is just sliced freaking bread, right? And you think, well, wow, if that stuff is so good, why isn't everybody on it? Why do we still have this warfarin thing? And the answer to that is what? Why do we still have warfarin? Because you know, as you know, we monitor warfarin blood levels, but we don't monitor these others. Why? Because of where they work. They're very specific to a particular agent. So it's not as involved. But why do you continue to see warfarin, and why will you continue to see warfarin for some time?
Cheaper?
No. Mm-mm. Because it is so effective. These other agents have yet to trump the outcomes associated with warfarin. So we're going to talk about warfarin specifically. And of course, it interacts with several, and your copies probably doesn't show it as well as mine because I had a color printer, but you'll see there's 4 different locations. These are vitamin K dependent enzymes that warfarin interacts with. Anybody know where the name warfarin comes from? I'm full of worthless trivia. No one pays me for it, so maybe Rich, if you see this, you can pay me for some worthless trivia. Warfarin actually was discovered, step back in time, I think late 20s, early 30s. Cattle in the state of Wisconsin were mysteriously dying. So farmers took these cows to the vet school in Wisconsin. And through some research, they discovered that these cattle had been eating a particular plant. And they isolated this chemical called Coumadin from the plants, hence Coumadin. They sold the rights to a pharmaceutical company, and they still get royalties for this today. And hence they have the Wisconsin Agricultural Research Foundation, WARF, and that's where the name warfarin originates, and that's where it is. So just so you know. Now you're also going to hear this, oftentimes your patients say, they're giving me rat poison, right? When you hear that, it's very important that you explain to the patient, we're not giving you medicine because it worked good in killing rats. On the contrary, it is a medicine that's effective in killing rats. Being a farm boy, my uncle had taught me that one of the reasons this particular type agent is so effective is because rats are very intelligent. When there's a new food source, rats don't just go like us elementary kids charging, to the cafeteria to chomp down. Oh no, they're going to send a scout. If that scout dies on the way back, guess what? We ain't touching it. But if it's a very slow process, scout eats, comes back, the whole herd goes, you eliminate the herd. So it's a very effective form. So we're not giving them a rat poison. It's a medicine that we've learned can be effective in eliminating rats. Big difference. So when we talk about warfarin, why the intense focus on warfarin? We monitor warfarin constantly. And what do we use to monitor warfarin? Anybody? PT-INR. What does INR mean? International Normalized Ratio. Whoop-de-doo, right? Well, there is some whoop-de-doo to it because a few decades ago, there were different numbers for different labs depending on where you were. So if you went to a lab in California, they had certain numbers. You go to a lab in North Carolina, they had certain numbers. You go over to Europe, they had different numbers. So you show up at one of these places and say, hey, I got a number 6. They're going to put you in the hospital. And they begin to realize, wait a minute, 6 for you is normal, 6 for us is abnormal. So the actual labs across the world got together and created an international normalized ratio. So no matter where you go, everybody's speaking the same language. And that number, we want it to be what? 2 to 3. You need to say that out loud, 2 to 3. You need to hammer that because that's extremely important. See, this is where we have some of our big concerns in sentinel events. Imagine Mr. Smith, you've been seeing him, 2, 3 times a week for the last 4 weeks, and you discharge him. And Mr. Smith, that afternoon, he's brushing his teeth, slips, hits his head on the sink, and guess what? Starts having a headache, goes to the hospital, then he dies from hematoma. Then they start saying, oh, gee, what's going on? They realize he was on warfarin. And then our quality team, our sentinel event team, because there's a death involved, when the patient was under our care, we have to review the information. And we find, oh, they're on warfarin. What were the labs? Oh, no. Did you check him? No. Why not? Because the doctor's doing it. Oh. Did you educate the patient? No, because the pharmacist did it. We see this more than we like, and it's a very frightening thing because, see, when you get in front of that attorney and they begin to depose you and they want to know, wait a minute, you knew they were on warfarin, but you didn't monitor the labs and you didn't do anything? No. They're like, ching, ching, I got you. So we want you to be very aware and very involved in monitoring, checking INR, and educating the patient as well. Because this is where we get in trouble, and this is where we can stay out of trouble. One of the things, when I was preparing for this kind of struck me, and it may not strike you, but this really kind of caught my attention. This is from Facts and Comparisons. This is Pradaxa, drug interactions. There's only one page. Here's Xarelto, drug interactions. Only one page. Here's warfarin, 2 pages. Let me make this very clear, folks. Everything interacts with warfarin. Everything. Smoking, lack of exercise. Let me guess. Are the majority of your patients obese? Yeah, right? Are they diabetic? Yes. Are they immobile? Yes. Guess what? All this stuff makes this more dangerous. Aging makes it more dangerous. Why? Because of this thing right here, right? One of the other things I want to emphasize, because again, people love to read the internet, right? And they love to talk. Well, I took this particular herbal agent and it made me feel good. Well, I want some of that too. So I simply recorded, now there's a list of them, but I just put on here just a small list, just because these are the most common that I hear about all the time. Ginkgo, golden seal, and nettle. All these interact to make warfarin more potent in terms of its outcome. Now, diabetes. The majority of your patients have diabetes. Any idea the connection between diabetes and adding a risk factor to warfarin? How I explain this to my students: everything you do, there's a risk involved when we talk about therapy, medication. When you came to work today, there's a certain risk, right, of harm. So if you came to work today going 80 miles an hour, it's another risk level. If you came to work at 80 miles an hour with your hands off the steering wheel, that's another risk level. You came to work today at 80 miles an hour with your hands off the steering wheel and you're talking on your phone, that's another risk level. And the same thing applies in the world of pharmacy medications. Age, obesity, hypertension, all this is another layer of risk factors, and you need to be aware of that, because the higher that risk factor builds, something could go kerplunk. Diabetes. That, folks, is your cardiovascular system. That is your heart. These are your arteries, your arterioles, your capillaries, then your venules, and then your vein. when people have diabetes, what do they die from? Because they don't die from hyperglycemia, right? Because you got people walking around 400, 600 all the time. What do they die from? Caused by what? People with diabetes die from complications related to microvascular disease. What's that all about? Glad you asked. This little jewel right here is what we call the capillaries, folks. Now again, we're going to step back in time, anatomy and physiology. Because remember, this capillary is so tiny that red blood cells line up one by one to march through this capillary, and as they do, they release oxygen, pick up CO2, release nutrients, pick up waste, and they just move on down the line, right? This tissue, this capillary tissue, is only one epithelial cell thick. Very, very delicate. So what? How many of you folks have had Bojangles sweet tea? Right? Right? Cracks your teeth, right? You know you've got something. Well, let me explain. In the blood, there is a measurement, and you see it on your lab reports, there's a measurement called osmolarity, and it's an important measurement. What's normal osmolarity? Anybody? We just round up to an easy number. 300 is what we just kind of rounded up to. This measures the amount of particles. When we do TPN, we do other things. It's something we are very aware of, right? When osmolarity measures particles in a container, right? So Bojangles sweet tea, right? They start with a bucket of just tea, and then they get their scoop out. 1, 4, 38, 55, right? And then they begin to stir it up. What's happening every time they put a container of particles in there? The osmolarity increases, right? So imagine when you've got a hyperosmolar blood level constantly. What do you think is going to happen to these very, very delicate tissues? Because this, right? Because what if I walk behind you all day long and I'm rubbing your hand like this all day long? What's going to happen to that tissue? Right? Inflammation starts. It tries to rebuild, and you break it down again. And it tries to... Same concept here. You've got such a hyper-potent irritation here, it damages this. And guess what? It begins to crack. Now, let's see. These capillary things, could they be located in some rather important places like the eyes and the kidneys and the brain, the heart? Yes. That's the reason you see blindness. That's the reason you see dialysis and strokes with diabetic patients, because these things are being damaged. It's another risk factor. So when you're talking about anticoagulation and they're obese and they've got diabetes and they're not exercising and they've got liver issues, all this comes into play. Vitamin K. We talk about vitamin K all the time. What do you tell your patients about vitamin K when they're on warfarin?
Either don't eat those things or eat a consistent amount.
Did y'all hear that? Eat a consistent amount. Why? Why? Because what we talked about before. Do you really care how much vitamin K they eat as long as you're monitoring the INR? No. Because what am I going to do? I'm going to freaking increase the dose. Eat away. This stuff is healthy for you. That is true on the internet. Okay? Have at it. I'm not going to stop you. But what I'm going to ask you to do is don't start and stop constantly, because then I can't keep up with changing this so it's constant. I gave you folks, I like this particular handout because it is a top-down illustration of the foods with the most vitamin K in it. So when you're talking to your patients, you can really give them some guidance. Kale is at the top of the list, and then it works its way down. So this is a very good guide to know what the impact will be. In our normal diet, the vitamin K we eat has very little influence on warfarin. You only get about 0.1 milligrams a day in your normal diet, and it's going to take about 10 times that amount to begin influencing this. So unless you're really eating kale a lot, it's not going to have an immediate influence. But there again, as we've already talked about, age has an influence. How you metabolize has an influence. So how do we get around it? We monitor, we monitor, we monitor, we monitor. And we educate the patient, watch out for this, watch out for this, watch out for this. Because, Mr. and Miss Patient, I'm sorry, you're at a high risk. You'll be lucky if you simply wake up dead. That's probably not going to happen to you. You're going to have a stroke, you're going to be an invalid, and you're going to have a very tough life. Sometimes you need to make sure they understand this. Because if they're not paying attention and contributing to watching out for the danger of this, let them know. You're driving that car at 80 miles an hour. Watch out. Yes, ma'am.
Have you heard of that?
Yes. We in the pharmacy world, we actually have a list of medications that are brand name only type drugs, and that's one of them. Levothyroxine, same thing. There are patients, because of this piece right here, how it's absorbed, how it's processed here, and how it's processed here, the binding components of that capsule may interfere with how it's actually released. So yes, going back to a trade name, brand name medication can actually resolve that. And we've seen that before. So you have to be mindful of that. Because again, insurance companies, they don't mind paying for generic. They'll fight you tooth and nail to pay for brand name.
How accountable are we for that?
Excellent question. The question is, if the patient has their own machine and they're doing their own monitoring and they're reporting it to the physician, how do you do that? I'll defer to Robin. How do you want it done, Robin?
Well, we want to see a value in that chart. So we don't want to see what we've seen before, patient monitoring or doctor monitoring. We want to know what that number looks like and make sure that that doctor's getting the information.
Right. Just saying it's done because the patient did it. Well, the patient machine, is broken or it's not calibrated. When you're in front of an attorney and they say, well, did you know that? Did you confirm? Did you calibrate? Did you validate? No. Why not? Because the patient's doing it. Then they're going to just smile and say, can I have your money now? Because I'm going to take it anyway. That's what they do. So just record what their numbers are, put it in your chart, and that it is being communicated to the physician. That's what we need. Excellent question.
And when it was last validated?
Yes, that's also helpful. And if you have a chance to somehow, right. All right. I'm going to also talk about this for a moment as we talk about risk factors. And I know you folks way down there probably can't see well, but I'll try to make it better, bigger.
So is the physician office also responsible for making sure that their patients' machines are calibrated and all that kind of stuff as well?
I don't have the expertise to answer that from a medical legal standpoint, but yes, that is technically between the patient and the physician. If the patient is going to be self-testing, it doesn't matter what device they're using, scales of any sort, then they need to be responsible for that. We talked a little bit about the warnings, the dangers of bleeding out because our INR is too high. But we don't always focus on the other side of the coin. This is your blood vessel, and this is what we call atherosclerosis, plaque. Now, just so you know, this is predominantly made of cholesterol, obviously, but just for your edification, when we speak in terms of HDL and LDL, that's not cholesterol. LDL and HDL are simply trucks, and they just drive this cholesterol to a location. Now, the reason HDL is considered good cholesterol is because it takes to the liver, and the liver can process it and eliminate it. We've got some lazy drivers on these trucks, and they're called LDL drivers, and they just kind of park along the side of the road and just take a nap and dump their load, and that's what happens here. And so what we've learned over time is if we know how many of these trucks are on the road, we got an idea of what they're doing with their load. So the LDL guys are constantly doing this. Now calcium gets involved and causes hardening of the arteries, blah, blah, blah. But in regard to anticoagulation, these little balls that float around called platelets. Platelets are involved with coagulation, right? Forming a clot. And I describe these as little bubbles. You know, when you take the little stick and you put it in some soap solution, you blow the bubbles. Those are very delicate bubbles, right? And you poke them and they pop. Well, it's the same concept here with platelets. They're designed, if something happens, you know, you get a cut or something occurs, they will pop. And as they pop, they send out signals, hey, we got a problem, come help make a clot. And they do, and they're very effective. So what do you think happens here? Grandpa's out chasing the grandkids, having a good time in the front yard. His heart rate goes up, his blood flow increases, and these platelets start bumping through this turbulence because of this narrowing of the vessel. What can happen? They can just bump into each other and pop. And what happens? Right? That does what it's supposed to do. Hey, we popped. Let's make a blood clot. And it does. But the INR was only 1.2. Egads. My body's not able to dissolve it quick enough. Normally, this happens to us all the time. We have these things happen in our body. And the body says, oops, sorry, mistake, delete, 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 and gets rid of it. But if the INR is not high enough, this little ball just floats around, and again, if it just happens to get lodged in a capillary, boom, now you got another clot. Now you got the opposite extreme. So when we're talking INR, we need to make sure we are therapeutic as well as not overdosing and increasing the risk of bleed out.
Can you speak a little bit about aspirin?
Ooh, I can speak a lot about aspirin. Excellent question, because aspirin, as you well know, is not specifically an anticoagulant like Xarelto and warfarin and so forth. Aspirin affects this little jewel right here. It reduces the platelet activation system. So it pops and it's like, you know, I have no message to send. Persantine and what's the other agent I'm trying to think of? Those agents will actually work here with the platelets and make them more pliable. So as they're going through this, you know, they just kind of slide on through without causing a rupture. But again, the question is, what about aspirin? Okay, risk factor, risk factor, risk factor, risk factor. I'm on fish oil. That can affect how blood coagulates. I'm on warfarin. That can affect it. I'm on aspirin. That can affect it. So all these become risk factors. So you have to be mindful of that. Again, monitor, monitor, monitor when we talk about warfarin in particular. Know the numbers and educate, educate, educate the patient. This is a new handout, a new tool, which I really, really like. And if you haven't already gotten it, Marie's got some to share. These are stoplights. And what I really like about these is that they're straightforward, they're practical, and it really, and this is something you need to make sure every time you go see Mr. and Miss Patient, hey, let's take a look at your stoplight. Let's remember the stoplight. Is it on your refrigerator where you can see it? And are you checking it every day? Because this is where we want you. We want you in the green. Uh-oh, if you're in the yellow, let's take a closer look. Holy moly, you're in the red. You need to be calling me, call the doctor. We need to take a close look at this fast. Because again, you really need to emphasize it's a very effective drug. It's a very dangerous drug. And we're here to make sure you get the benefit from it without any harm. There's information on the back as well for the patient. Again, some food items that, you know, just for them to be mindful of. But I really like this. Who to call, what number to call. Again, you'll see there's also some now for Plavix, aspirin. Again, these are anticoagulants. We got one for Xarelto and for DAX as well. Because again, what we're simply trying to do, the symptoms. Make sure that patient is constantly aware, oh gee, this could be happening because this amount in my blood might be changing a little bit. So as we finish up, again, let's take a look at your patients, right? Their risk factors. They've got this problem. They've got obesity. They got this problem. They got diabetes, right? They've got age. They got immobility. All these things add up. So again, protect yourself by making sure you're simply educating the patient, monitoring their numbers. Again, and it's unfortunate because we see this also. We do see this also. I have to emphasize this. Mr. Smith hits his head, goes to hospital, he dies of a hematoma. It's tragic, it's unfortunate. We go through the chart and it's very clear. We tested here, we sent the doctor the numbers here, dose change here, we tested here. Okay, your job is safe, you did it properly. We see that also. And when we have those events, we talk about them, we say, well, we did exactly what we're supposed to do, it's just unfortunate. It's just the nature of age. Other questions? And Robin will probably speak more on the lady's question about resources and so forth.
And just while you're talking about that kind of chain of command, if you've got a doctor that's not responsive.
Thank you. I've given this presentation at some of the other branches, and we do know from comments and from things they've shared, there are some physicians that for whatever stupid reason will not order the INR to be tested, monitored. I don't understand it. I do not understand it. But again, we do not want you to be at risk. We do not want our patients to be at risk. When you come across that, then you immediately bring that up to your supervisor. It can go to then Paula, it can go to Dr. Barkley. Dr. Barkley can call this physician, try to find out why are these things not being monitored. Because quite frankly, if they don't want to do that, we may not take their patients. Because we don't need to be involved in a medical legal issue because some physician was not willing to do the right thing. We see it in the pharmacy world with aminoglycosides at times. And we just will not dispense certain medications if they're not going to draw the labs properly. So thank you for that. Other questions? Yes, ma'am. That's an excellent observation, and thank you for bringing that up. Because again, can you imagine calling the physician saying, oh gee, this patient could be vomiting because we got alcohol that's not even touching the drug, but it shows up on my report. Can you imagine that conversation? Yeah. Click, right? That's the answer you'll get. Don't call me again. Don't ever call me again. But yes, those are part of the assessments we have to factor in.
And so how do you document that so that you have addressed?
That it's almost like a topical agent and an oral agent. There is no interaction.
So
They're on the same thing, but there's no interaction between the two agents, yes. Good question.
But would you still get dinged
No.
as not calling the doctor because it came up?
I'm going to defer those questions again back to quality because that was the other thing we've been talking about. Yes, I'm trying to help lessen the necessity to make those phone calls, and I am not one. I'm more on the preference of fax it. If there is symptoms involved, if it's a new combination of drugs and symptoms involved, then yes, you need to be on the phone with the physician. I'm not allowed to give you permission, but I would prefer it be faxed and say, just FYI, doc, here's something that you just want to be aware of.
And can I just...
We're trying to limit this to the home care, home base information. The beers are mainly wrapped around, again, the antipsychotics and the side effects associated with that class of drugs. But we'll have to have that conversation probably separate to answer it properly. I thank you all. You've been a delight to share with, and thank you for your time.